This is me. I am from UK originally, as you can probably hear from my accent. I've been in Canada for over 20 years, actually nearly 30 years now. And I came from New Zealand. I came from England to New Zealand and then to Canada, doing 2 internal medicine residency programs. And then I set up the Pain and Symptom Management Palliative Care Program at BC Cancer back in 1997. So I've kind of been around a long time. And over the years, I've got to know a number of the physicians here who do prostate cancer, and a particularly good nurse practitioner here who I communicate with on a day-to-day basis quite frequently. And I've also had the privilege of attending some of the meetings with the local prostate cancer support group. So I'm going to be talking specifically about medical cannabis and prostate cancer, but there's obviously no specific thing about prostate cancer. Medical cannabis is widely used by many patients with all different kinds of cancer. So most of what I'm going to be talking to you about is general. So we'll get to the specifics near the end. And now I should be able to press forward. Why is that not going? Hang on, let me just see why that's not going. I should be able to press forward. Oh, I see. It's got a tiny little icon right down in the corner. Is that going? There we go. God, you need to have almost a magnifying glass to see that little blue arrow. So I don't have any conflicts of interest to report. I'm not getting paid to do the talk today. I don't have any cannabis stocks or shares, though maybe that was a bit silly of me. I perhaps should have thought about that earlier. And though I do occasionally give talks for licensed producers, I don't retain their honoraria. I donate that to the UBC Division of Palliative Care. The one thing where I could potentially be accused of bias is that I am the principal investigator of a study at the moment, which actually is using study products, which are medical cannabis products that have been donated by a licensed producer. And they have not had anything to do with the design of the study. They have no ownership of the data. And I believe that I'm not in any conflict of interest with that. I don't earn any money from doing that. That's done nights and weekends. I'm part of my BC Cancer job. So I'm going to try and cover the brief sort of basics of how cannabinoids work and the practical aspects of accessing it in the post-recreational legalization era. And hopefully we'll have plenty of chance for discussion. And just by looking at some of the questions that people submitted beforehand, I was really quite impressed by the level of knowledge of many of the question writers. So clearly this is something that I have a pretty informed audience about. But I can't assume that everybody is in the same level of understanding as the people that wrote the questions. So here's the sort of the basic. The cannabinoid receptors, which are the receptors in our bodies that exogenous or outside of the body cannabis-based products hit. That's how they work. They're actually everywhere. They're all throughout our body, but there are more cannabinoid receptors in the brain than everything else combined. So clearly they do something pretty important. And if you look at the level of green in the little cartoon to the right, you see that the most green implies the density of the cannabinoid receptors, particularly CB1 receptors. There's 2 different kinds, CB1 and CB2 that we know of, and there may well be more that we'll discover in future. But the CB1 and the CB2 receptors seem to be responsible for the vast majority of the effects of cannabinoids that people are taking already. And in the brain, they're very densely packed, particularly in this part of the brain called the cerebellum. I don't know if you can see my arrow here, but the green bit at the bottom, either side of the brainstem, which will be at the back of your head, that's the area of the brain that controls coordination. So if you don't have a functioning cerebellum, you can't walk, you fall over. And if you try and point to something, your hand would wobble. So coordination is one of the things that can be most affected. But the other parts of the brain that are fairly densely populated are the ones in the middle, which particularly involve types of learning and regulation of movement. I'm going to move on to the next slide here. So that's the CB1 receptors. The CB2 receptors have completely different effects. They're in the cells of the immune system, so not in the nervous system. When they are in the brain, they're actually not part of the neural activation part of the brain. They're part of the structural cells or glial cells. This is kind of the glue that holds your brain together and holds it in a three-dimensional structure that allows all the different neurons to have their little nerve endings that connect with each other. So it's the glial cells are responsible for the connections that we make between the different parts of our brain. And these glial cells have a powerful anti-inflammatory effect. And when they're stimulated by CB2 receptor agonists, which means stimulation of those receptors, they can have powerful anti-inflammatory effects. So, for example, that's one of the reasons why they're being explored for use after head injuries or post-concussion or after strokes. There's also multiple areas of the body that CB2 are involved in, particularly in the bones. So people that don't have good CB2 receptors, just born without them, seem to have a problem with their bones. So clearly, you're involved in that. And we know that CB2 receptor activity is also not stable. So the reason I mention this is because when you're studying the effects of drugs and different physiological functions of the body, you tend to start with animals and then you go to humans and you start with healthy humans. The problem is that healthy humans and sick humans have different ways of responding and different metabolism. So you can't necessarily assume that something that happens in a normal volunteer will happen in a person who is sick. So you actually have to study these products in people who actually have specific conditions. Another thing to be aware of is that the endocannabinoid system, which is how our body regulates these CB1 and CB2 receptors ourselves, even just normally as we're sitting here, hopefully with no cannabinoids in most of your systems, your cannabinoid system is actually constantly adapting its activity to what's happening in the body. So if you're hungry, that's your cannabinoid system telling you. If you're tired, that's your cannabinoid system telling you. If you're happy, that's your cannabinoid system. So it's a ubiquitous system throughout the body, which means that it's hard to mess with because there's always unintended consequences. So if you take a cannabinoid for a specific function, you can't assume that it's just going to do that. It may have a lot of other effects as well. An example of this is a treatment to try to treat morbid obesity. You know how some people, when they take THC, or which I'm going to talk about, but medical cannabis or recreational cannabis, people get the munchies, they feel hungry. So the theory was that if you block the cannabinoids, then you'll make people not be hungry, so maybe they'll be able to lose weight. The problem is that they also became suicidal, and this product had to be withdrawn. So again, it may have been very good at preventing the appetite, but it also produced severe depression. So these are things that it's important to just be aware of. It's not something you play with lightly. So this constant state of interaction between the different sort of stimulating and suppressing cannabinoids, there are genetically some people that have abnormalities of that system. And it's quite interesting that there appears to be cannabinoid deficient states, and things like migraine, irritable bowel syndrome, fibromyalgia, chronic fatigue syndrome, cystitis. Those conditions often overlap in the same patients, so they seem to be very closely related. Cannabinoid excess states also seem to be somewhat related as well, and schizophrenia, morbid obesity, and attention deficit hyperactivity disorder all seem to be somewhat related, and most likely represent cannabinoid excess states. And CBD is the main cannabinoid that appears to moderate this tone. So I have to say, though, that we're very much in the early stages of understanding this, and it's not even fully accepted by the sort of medical literature that these cannabinoid deficient and cannabinoid excess situations are real. At the moment, some people say they're hypothetical. I think there is some quite good evidence for them, but it is difficult to prove. This is just a slide to show that medical cannabis is not a new thing. You can see the pipe there. This is showing that medical cannabis as well has been used for millennia, not just centuries. And it's often sort of advertised as leaves. Whenever you see a picture of a cannabis dispensary or a cannabis product or a health information leaflet about cannabis, normally you see a picture of the leaf. But in actual fact, the majority of the cannabinoids come from these little pistils, which are part of the flower. The flower, if you actually look very closely at this picture, you'll see little hairs on the pistils in the flowers, and there's little droplets of oil on these little hairs. And it's actually those little droplets which are responsible for quite a lot of the cannabinoids. There are cannabinoids in the leaves and in the stems, but it varies quite a lot. And the THC is particularly concentrated in these pistils. So I've talked already a little bit about THC and CBD, but it's important to recognize that it is really a very complicated physiology, and we don't really understand it fully yet. Just as this interrelationship between the CB1 and the CB2 receptors and the balance is variable from one person to another. The effect of THC and CBD also influence each other and varies from person to person. We know that THC leads to the main recreational effect, which is euphoria, but we also know that it's involved to an extent, at least in pain relief and the anti-nausea effects, because synthetic THC equivalents are effective for pain relief and nausea. And there's no CBD in them at all. In fact, none of the other compounds in medical cannabis. So we know that THC actually does something medically. It's not something to be completely avoided. But we know that when people take THC in the presence of CBD, they can handle higher doses and they get less side effects. So this CBD on its own has an effect. THC on its own has an effect, but put the two together and you get different effects. So it's not like 1 and 1 makes 2, it's 1 and 1 makes 3. So it's quite complicated how those interact. And it's quite likely that it's better to have a mixed product, so some CBD to try to reduce the side effects of the THC, but still maintain the THC effects. The effects that CBD can have on its own are relatively recently being explored because we haven't really had access to high-dose CBD for a long time. This is only a very recent advance. And it appears that the anti-epileptic effect is probably the one that's going to get the earliest approval. There's a product that's being developed called Epidiolex, which is already approved in the US. And I think it's either approved already in Canada or about to be. And it's for children with a couple of rare types of very severe epilepsy. If anybody's seen the films about Charlotte, Charlotte's Web, Charlotte was a little girl in Colorado who had one of these horrible seizure disorders, and she did very well with a particular high CBD product produced by a local family farm, and that really generated a huge amount of interest in CBD as an anti-epileptic because of this little girl Charlotte. It also appears that it's an antipsychotic, and everybody thinks, oh, you shouldn't take cannabis if you have a history of psychosis and, can cause schizophrenia and things like that. But that's the THC. CBD appears to actually have a beneficial effect, not promoting psychosis. And we haven't really had any good new antipsychotics for a long time, like 20 or 30 years. Most of the advances in antipsychotics have been minor tweaks and reduction of side effects rather than actually changing the way things work. So it's actually quite exciting to think that CBD may have potential for a huge quantum leap ahead in management of psychosis. But again, really important that it's just the CBD and doesn't have the THC because THC can make things worse. So again, very important as to where you get it from. Don't play with it, not knowing what you're taking. Anti-anxiety effect and anti-inflammatory effects are also being reported, but again, they're not fully understood as yet. So access to cannabis or cannabinoids, there's essentially 5 different ways you can do it at the moment. The third one here, the purple one here, is the new one. So I'll just briefly cover the first 2. You can have legal prescribed products that your doctor would give you a prescription. You take it to the drugstore, you fill the prescription, and you take it home. You can put it through if you have extended health that covers it. If you have benefits programs, you'd be lucky to get it covered because Nabilone and the spray, nabiximols, are both very expensive. But Nabilone particularly has been covered by some groups. Nabiximols or Sativex is quite expensive, is not covered, and I think I've got a couple of slides on that. But these are legal prescribed products that you can try and take home with you. Then you can have the legal plant-based medical products, but these you have to purchase from an online licensed producer. So it's only by mail order. This is one of the few situations where buying something on the internet is better than going to a store. It's the opposite of how you would buy, shoes or kitchen appliances. The legal recreational products are where there is a lot of confusion because the licensed dispensaries now, the ones that you can walk into that are licensed by Health Canada, are only approved for recreational use. And you can't guarantee that you're going to get any information at all from them, from the dispensaries. Having said that, the products themselves are tested and guaranteed to be free of molds, free of pesticides, and will be what's on the label. Then you get to the ones that I've put in red here because they're not recommended, but I include them because we often have questions about it. And people that have been taking cannabis in a variety of forms for many years, some for medicinal and some for recreational purposes, often find that these work for them. Some people have figured out how to grow it themselves, and good for them, but it's actually really quite hard to do that. And I wouldn't recommend it unless you're extremely experienced and have a lot of equipment and access to the specialist help to make sure that it's safe. So most people get illegal products from either unlicensed dispensaries or from friends. That's actually the most frequent source when you survey groups of patients, which is a problem. So going on to some of the conditions that, so I'm just going to see if that goes away. There we go. Conditions with claims for benefit. There are huge, great long lists. I mean, this is only a selection of the ones that are approved or with good evidence or promising. There's another list, probably another 3 or 4 times this many, of conditions where there have been anecdotal case reports. And if you go on the internet, you'll find people talking about how much it helped them for their particular problems, but nothing more than just isolated case reports. So as you can see here, the ones in red here are the ones that Health Canada approve. So that's muscle spasm. It's actually multiple sclerosis. That's my error, not ALS, MS. It should say MS there. Spinal cord injury, pain in cancer or neuropathic pain in non-cancer situations, and wasting in AIDS. And this is specifically for Nabilone. There are a number of other conditions, though, like schizophrenia with CBD, insomnia with either THC or a mixed product, anorexia in cancer, anorexia meaning loss of appetite, anxiety, widely used for anxiety, also widely used for arthritis, particularly CBD, and quite a bit of interest in bladder dysfunction as well as epilepsy. And there's a whole load of these other conditions, which I'm not going to list, where there are a consistent reports from multiple different people, all of whom don't seem to know each other and don't seem to have any vested interest or conflict of interest, suggesting that there is some benefit. So really in need of more research. When you look at a lot of the studies and reviews that have already been done, and there are many, many reviews. I actually did a review of systematic reviews just recently, and there are about 50 of them in the last 5 years. But they're all reviewing the same studies, most of which are poor studies and old studies. And most of them are coming to it from very much of, I feel, a preconceived idea of what they're going to find. Often the studies that are being reviewed are using only THC or synthetic equivalents, and they're pooling them all together. And you can't say that THC and CBD are the same thing at all. So you can't pool those results. And that's a big mistake that many of the systematic reviews make. the actual balance of the cannabinoids in a lot of the products is often not reported, so you have no idea what people have been taking. Some of the studies, particularly the smoking studies, use fixed dosing schedules. So as we know, people are very variable, and what might be a tiny dose for one person may be excessive for another. So if you tell everybody that they have to take the same dose, by definition, you're going to get a load of people who are underdosed and a load of people that are overdosed. So allowing self-titration is really important for clinical trials. So if you're reporting side effects in a study that's not allowed self-titration, you might say the side effects outweigh the benefits, but that's because the side effects have artificially been created by the poor research methodology. And then the last thing, which can be very confusing as well, is that people are reviewing studies that have been done by routes or using products that are not recommended now, particularly inhalation. We really don't want people to be smoking anything, even vaporizing. We're not sure about, because it hasn't been studied for long, and there was an outbreak of vaporization associated severe respiratory distress syndrome recently. We don't really know quite what it was from. It doesn't appear to be the cannabis. It's some kind of vehicle that was used. They thought it was vitamin E oil for a while, but even that, it seems there are people that have had this condition even without the vitamin E oil. So we don't really know enough about vaporization to say that it's any safer than smoking. So the best thing is don't breathe it in. You should only be breathing nice, clean air. A number of questions that came in beforehand were about cannabinoid research, and this is actually really very difficult to do, because in traditional cancer studies, you always have parallel groups. You have a group of people taking a study intervention, and then you have another group of people who are not. They're the placebo arm, and you follow them in parallel. But that really doesn't work well for something that people can go and buy on the street. They can get easily. So in a parallel group design, it's hard to find people, particularly in BC. I don't know what it's like anywhere else, but it's hard to find a cancer patient that's not taken or taking cannabis in some form or another, because so many people are. And even if they say they aren't, they might be. Dose response relationships are also not linear. And again, the traditional model is if you give somebody a little bit of something and it does a little bit of what you want it for, then a bit more is likely to do more, and a little bit more of that than that will do even more. The problem is with medical cannabis is it doesn't work like that. So you can have an effect, like particularly with anxiety, a little bit of THC can have an effect on reducing anxiety. But then if you continue to increase the dose, you can actually make anxiety worse. So you can actually have it causing the problem that it's trying to fix. And the devil's in the details. And that point of where you go from being good to bad can vary from one person to another. So very important that these complexities are taken into consideration with research methodology. And whenever you're trying to do anything that's not traditional, the research ethics boards have little hissy fits. And they get very upset and don't understand. And the funders, whenever they're presented with something that's a little bit different to the traditional, they get nervous. And then if you're competing with things like immune therapies for cancer, or a comparison of two different kinds of radiotherapy, where everybody knows what the radiotherapy does. It's very much the known. A lot of the big funding agencies and people like the Cancer Clinical Trials Group, in the big Canadian group, they get very nervous about that. So they never say no. It just never makes it to the top of the list. It's just always relegated to, well, this is interesting, but maybe we'll think about it in the future. So I wasted about 4 or 5 years with trying to get funding from those groups to do the clinical trial that I'm doing at the moment, and gave up in the end. Challenges with doing cannabinoid research also are in finding a product to test. One of the problems at the moment is Health Canada requires the products that are being tested to have been produced using much higher rules, I guess, than the stuff that you can buy normally. So the factories, or the the places where they provide or they make the study products, which are the same that you would buy if you went to a licensed producer, they have to invest quite a bit of money in making it to this very high quality. And there's only 2 or 3 of the licensed producers in Canada that have a product which is actually approved by Health Canada. So that makes it very difficult to access for clinical researchers. You literally just can't get the stuff. The legislative and regulatory environment really has been extremely difficult. The problem up until about 2.5 years ago was that medical cannabis was listed as a narcotic. So the actual term narcotic implied that a whole load of different laws that apply to narcotics. And the narcotics regulations mandated that pharmacies handle it in a certain way. The countervailing regulation also said that the pharmacies were not allowed to handle it because they didn't have a DIN number. So you had 2 conflicting rules, both equally valid, one saying you could handle it and one saying you couldn't, but the conditions did not apply for both. So effectively it was completely blocked. Like there was no way you could do it. It was impossible legally to negotiate that. So when it was delisted as a narcotic, which was about 2 years ago, that really helped a lot. But Health Canada was not set up to do research. They had a cannabis office and they had a research office, but never the twain should meet. And you just got bounced around from one office to another repeatedly. But it has actually started to improve, and we have started to recruit with our study. But I believe we're the only one in Canada that's actually got this far to use an actual extract that's available for purchase. So just a little bit of background on BC cancer patients, just so you can get an idea of the sort of magnitude of use. And there have been studies from Alberta and Ontario. I don't believe there's been any in the Maritimes, but certainly my communications with my colleagues who are interested in medical cannabis across the country, including Manitoba and Saskatchewan, they report very much the same data as this. So hopefully this is representative of wherever you're from. We sent out 3,000 surveys to basically every patient that attended BC Cancer in all of our sites, which all around the province, on one index day, which was like a Wednesday in January. It was not a bank holiday week, it was just a regular day. And we got a pretty good response rate, actually, 800 out of 3,000 responses, for considering, large proportion of our patients don't speak English or don't fill in surveys because they don't have time. I thought that was actually a pretty creditable response rate. And we found that half of the patients had used cannabis at some point. But what surprised us, we weren't surprised at the half having been prior users, because most of those were recreational. But half of them were currently taking cannabis, and the vast majority of them were taking it for either relief of symptoms, or also for sorry, I've gone forwards. Also for treating cancer. And as there isn't any evidence at the moment that it has any impact on cancer outcomes, this was actually quite alarming to us, because when you're taking it for symptom relief, you have something to measure it against. So if you find improvement in your symptom, like your nausea gets better, then you won't need to increase the dose. Or if your pain gets better, once you have adequate pain control, you don't keep increasing the dose. Whereas when you're taking it to try to treat your cancer, there's this feeling that more must be better, and you've got nothing to measure it against. That's when people run into trouble with having a lot of side effects. And I've seen people get very severe side effects, particularly delirium. One particular patient never recovered from his delirium. He stayed confused right until he died, and it was really sad because he was a young guy with a young family, and the family lost a lot of opportunity to communicate with him. And it was because he was trying to cure his cancer with medical cannabis, taking huge hundreds of milligrams a day of THC. It just kind of fried his brain. It was awful. So please don't do that. We repeated the survey in January 2019, which is about 4 months after the recreational legalization, just to see if things had changed, and essentially found that there was more interest in use. Particularly, people were more willing to admit that they were taking it for recreational as well as medical purposes. But we also found that there were more reported challenges in trying to access their products. And that was because a lot of the illegal dispensaries were shut down once recreational became legal. And a lot of people have been buying their product from recreational dispensaries. We did another survey just of people that actually take it. This was soliciting people who were already on it. So it's a totally biased sample. But the people that were on it and found it helpful, that continued to stay on it, took it despite these side effects. So these are normal and these are expected. They are adverse effects, but most of the people, in fact, all of the people in the survey said that they tolerated the side effects of the medical cannabis product much better than they did other pharmaceuticals that they had been given for the same indications, like opioids or antidepressants or benzodiazepines. So dry mouth seems to be quite common, at least half. Some sedation, and a lot of people were using that for good effect because they were finding that it was helping them to sleep. Some people did get a little dizzy, but that tended to get better with time. So people would slowly increase, and as they got used to it, they would find they'd be able to tolerate it better. But certainly a good reason to always start low and go slow. Don't start out with a great big dose. Tummy rumbling was interesting, and it does seem to have a slightly slowing effect on the bowels. So not as much as a lot of the painkillers that people are generally prescribed, but definitely something to be aware of. And this issue of confusion is definitely something to be important. It's important that people consider. And if there is any signs of confusion, it probably means you're taking too much, and it's probably because you're on too much THC. Even if you're taking a product which is listed as being primarily CBD, especially if you're taking it in big doses, it may be the THC that goes along with it that's messing with your brains. There are some people who would strongly recommend we don't have them try medical cannabis. Psychosis, especially with THC, and we don't have enough data yet on CBD as an antipsychotic to recommend it to anybody, though it is promising. It's not there yet in terms of the data, and certainly not with any product that is not tested and certified THC free. People who have unstable heart problems, I actually have heard of a number of cases where people have dropped the blood pressure and actually had strokes. I know of two people who are in their 30s who had strokes. They were taking very high doses of a high THC concentrate oil, Rick Simpson oil, and then they smoked cannabis on top. And have had catastrophic strokes. So some of it is probably the THC dropping the blood pressure and affecting our body's ability to regulate blood flow to the brain. But also smoking, when you smoke anything, you inhale bits of cellulose and products of combustion. It would be the same whether you were smoking a cigarette or a twig. But that stuff is quite bad for you, and it makes your platelets in your blood quite sticky, and it also can cause spasm of the blood vessels, particularly with nicotine, and that can reduce the blood flow to a critical point to actually have people have strokes, and sometimes arrhythmias as well with very high doses. These are generally only seen in people taking massive doses recreationally. I've never heard of anybody having problems with this with low doses from medical consumption, but it's something we just have to be aware of. We don't like to use it in children. People's brains seem to develop up until around the age of 25. So youth, it's not just children, but teenagers and people in their early 20s. Probably not a good idea, especially if they have a long life expectancy. Obviously, if it's a child with cancer that's approaching end of life, that would be a very different situation. It's the long-term side effects that are people concerned about. And then just to draw people's awareness to this severe cyclical vomiting, which is sometimes seen in people who are heavy cannabis users. In BC now, one of my colleagues who works in emergency says he sees 2 or 3 of these a day. So this is not a minor thing, and it's very unpleasant. It only responds to hot showers, which is really weird. If somebody feels sick and then they get in a hot shower and they feel better, it's probably their cannabis. So the only treatment for that is gradual withdrawal. They need to stop consuming it, otherwise it will carry on. Not very many interactions to know about with medical cannabis, but there is a drug called clozapine, which is an antipsychotic, which has a very significant interaction. That's probably the main one. The other one, just to be aware of in cancer, is that immune therapies they stimulate your immune system to sort of reject the cancer cells. And particularly CBD, which is can be an immunosuppressant or an anti-inflammatory, might reduce the effectiveness of the immune therapy. So we haven't actually seen any impact on survival yet, but we've only really had one good study in relatively small numbers of patients. And the surrogate for survival, which was the progression-free survival, was actually significantly worse in people that were taking cannabis. So this was self-declared cannabis, and it wasn't noted whether it was THC or CBD or whatever. But this is a signal that there's quite a high probability that people on immune therapies should be avoiding anything anti-inflammatory or immunosuppressive, which includes medical cannabis. So moving on, we're nearly at the end now. The licensed producer oil, just to give you an idea of how much it costs and what it would look like if you were trying to buy it. You can ignore the fancy names. All the different producers come up with these fancy names just to try and attract the recreational users. But the main thing to look at is the THC and the CBD content. And as you can see, though the THC is the main one, there are some other cannabinoids which have similar effects. So THCA, you have to really add in the THCA to the THC to get the total cannabinoid content there, and the same thing with CBD, but you can see they're very close. It doesn't make a whole lot of difference. And this is quite a reasonable strength. It's not very concentrated, but with 1 ml, which would be 20 drops from a little dropper, you would get around 8 to 9 milligrams of THC or CBD. And for most people, the dose that you would start with would be about 2.5 milligrams for a dose. So 1/3 of a mil of this would be a reasonable starting dose. And if you can see, if you get 60 mils, that would be about 120 doses. And if they were taking 2 doses a day, that would last a month. If you're taking 4 or 5 doses a day, obviously you would get through it quite quickly. And if it's $150 a pop, that's not cheap. And remember, a lot of extended health and medical insurance companies will not cover this at all. The one way you can get some financial money back is if you buy it from a licensed producer, you keep your your receipts, then you can submit them as medical expenses at the end of the year. So that can be quite a significant cost, but you're not allowed to do that if you have not bought it from a licensed producer. So this is a very good reason to use the proper LPs online that Health Canada recommends. So this is just a little bit of a summary here, but clearly a lot more research is required. But I personally believe that there is enough evidence of symptomatic benefit with some of the cannabinoid products already available that are providing people do it under medical supervision, and they get good quality products that it is worth trying for certain symptoms. The magnitude of benefit may be small and not everybody responds, but in general, people tolerate it pretty well. There are these small groups of patients who we should be particularly careful with. So youth, people with history of psychosis or active confusion, or if they have unstable cardiac problems, making sure you don't take it concurrently with immune therapy until we have more information. And if you don't know what to start with, I would suggest going with a 1-to-1 oil, which will be a THC to CBD ratio 1-to-1 from a licensed producer that you buy online and not go to a recreational dispensary. When you get your product, always start low. And if you can figure out the concentration from the label and work out what about 2.5 milligrams is, that would probably be a good dose for you to start at. And when you have access to participate in clinical trials, I really encourage you to do so. I can go through the eligibility criteria for the study that we're doing here in BC, but we are also going to be opening in Calgary, in Winnipeg, in Kingston, Ottawa, and anybody in Lakeridge Health, which is Eastern Toronto. So the study that we're doing is going to be accessible to people in not just in BC, and I would really encourage you to participate. It is for symptom relief. It's not about trying to cure cancer, and patients have to be stable. They need to not have any treatments which come and go during the treatment period, which is 48 days. It's 16 days per cycle of trying the different products. It's a high THC, high CBD, and a 1-to-1 mix and a placebo. And you have 4 days on each, 16-day cycle, and there's 3 cycles. And during that time period, you shouldn't be having things like chemotherapy or radiotherapy because they may impact the symptoms. And we need to know that if there's a change in your symptoms whilst you're on the study, that it's because of the study products, not because of something else. You're also not allowed to drive or drink whilst you're on the study. So if I've got the questions that were submitted up in advance, would you like me to go through those now, Rochelle, or do we want? Are there any questions in the chat?
No, nothing yet. But if everybody who's listening, you want to start sending them into the chat, you can.
Yeah, now is your time. Be thinking of your question and scribbling furiously. So number one, symptomatic benefits. There were a number of questions which all kind of different wording, but all came down to is there symptomatic benefit? And I think as I've tried to present in the study, it is complicated, but I do think a 1-to-1 mix is a reasonable ratio to try. We actually don't know if other mixes are better for other symptoms because I haven't had any studies on this. That's why I'm doing the research project. Like if I knew the answer to the clinical question that I'm asking with the study, then I wouldn't need to do the study. So yes, you probably need some THC. Does the addition of CBD make enough of a difference to warrant the extra cost? I don't know yet. It might be that if you're just taking a little bit for sleep or anxiety or nausea, that you can get some cheap, low concentration THC oil, and that may be just fine for you. But if you're treating other conditions like anxiety, maybe it's more important to have CBD. And all of these things we're going to tease out with the study because everybody's acting as their own control. So we're comparing them. Starting low and going slow is most effective pretty much with everything, but particularly with medical cannabis. And just the question about, there's a lot of questions about CBD. And I would caution you that we really don't have any information at all about it, either for symptoms or as an anti-cancer treatment. And it can be very expensive. So, don't anybody go out and think that getting a high quality, high CBD is guaranteed to help you. It might actually not help you at all, and it may set you back a lot of money. Maybe in 3 or 4 years' time, I may be able to say something entirely different, but at the moment, we just don't have the evidence, and there is potential for harm. A little bit about the anti-cancer work, which I think is fascinating, and it was actually quite nice to be asked to do this again because every time I do it, I get to re-review the current evidence. There have been some quite interesting animal models, particularly in mice. There's some studies where they've taken human cancer cells and put them into mice that have been bred to not reject them. So effectively trying to create the environment like of having cancer cells in humans. And then they've treated these animals with various different doses of various different products, so THC and CBD. And the ranges of doses that are being used are huge, even 0.5 milligrams per kilogram. For a human, say 70 kilograms, that's going to be 40 milligrams. 40 milligrams as a single dose, that's the lowest. We start with 2.5. So yes, you can maybe show something happens in an animal model or in a test tube, but does that apply to real people? Like you actually couldn't get that much into a human physically. And there was somebody who asked specifically about direct injecting into the prostate, which is actually a really good question because that it might actually, theoretically, if you think about it, well, you need to get the highest concentration to where it needs to be. Maybe if you just inject it right into the cells, it actually does make sense. The problem is that there's been not one single study about it that I've been able to find, not even in animals with prostates, let alone humans with prostates. a number of people were very keen on volunteering to participate in studies, and we're asking about who's doing research. And there are multiple studies. The Dutch, the Australians, the Israelis particularly have always been very keen. There are a number of Canadian studies going on, but again, all in animals, and most of them involve investigational products which are derived from cannabis, so not cannabinoids that you could go out and buy. They're synthetic cannabinoids or specific extracts. So nothing that you can actually, have a brand name on or go and purchase yourself. So potential for something in the future, but a long way away yet. Have there been any insights into delivery mechanisms? Basically oil. Oil. You can encapsulate oil into capsules and have them swallowed if you don't like the taste of it, but it's basically just still getting the oil in. It's a fat soluble substance. Both THC and CBD dissolve in fat, so you need fat to enable absorption. If you inhale it, the fat lining of our membranes in our lungs helps facilitate the absorption. But if you're swallowing it, you actually have to have it in fat in order to be able to absorb it. So having it as a tea is not very effective. You can swallow as much cannabis tea as you want, but you're not going to get very much cannabinoids out of it. It'll just all end up in the toilet, which is a terrible waste. Is there anyone looking at total oil extraction? And Rick Simpson oil was mentioned specifically, and no, most are looking at synthetic cannabinoids or mixes. But the company that I'm getting the study products are using a total oil extraction method, but it's being done in a proper licensed and approved facility with very rigorous supervision and monitoring of their methods. Test subjects, yes, if again, with my study, it's called CAFCAS, Cannabis for Cancer-Related Symptoms. Very happy to take any patients who think they might be eligible. And the last specific question, has any research been done surrounding the vaping or smoking related to anti-cancer? And no, there's not one single study on that. I think I've talked about cost a little bit already. It's expensive and it's pretty hard to get covered, but there have been a couple of people I know of who've challenged WorkSafe BC. One was approved, but I believe for only THC, only CBD and not THC. I think that's something that probably has to have a legal challenge. Somebody's got to make the investment in time and actually challenge so that the funding agencies are forced to cover it. Research resources are not really limited at the moment by funding because there are lots of non-traditional funding sources that are willing to sponsor this, and a lot of disease-related groups like the Prostate Cancer Research Foundation that are interested in supporting these kind of things. But the traditional cancer research institutions like the Cancer Clinical Trials Network are really not there yet. You have to have this biological plausibility for a study, and really the case for the human trials, particularly in prostate cancer. I mean, they just haven't, they've not been made for any kind of cancer, but prostate cancer, though prostate, brain, and breast are the ones where it seems to be most promising in animal studies, still a long way away from being able to suggest that human studies should be done. And observational studies, because so many people are taking cannabis, may show a proof of concept, but they're very difficult to do when the consumption of the product is so variable and people are getting all sorts of stuff from all sorts of different places. It's also might be difficult because with prostate cancer particularly, we have such excellent treatments already, and 5-year survival rates over 95%. So it's very hard to show a difference between something that's already amazing and that's something that's slightly more amazing. Statistically, that's extremely hard to show. I think that the symptom-related research is where we're going to see the big expansion in the next few years, and that's limited much more by regulatory issues through Health Canada than by the numbers. Like once I gave up on the CCTG, I was actually able to find funding quite easily. So I will leave that actually, I'm not going to leave that up because it's boring looking at a screen that just says other questions. Maybe I'll leave it up just for a minute or two so that if people want to email me with specific questions that I haven't covered already, or that you think about after this session, I'm happy to take emails. I don't mind at all.
And there are a couple of questions here in the chat, if you don't mind.
Okay, I'm stopped sharing now, so I should be able to see the chat. Okay.
They were sent to me, so I'll just read them.
Okay. Shall I do? Why don't you do yours first, and then I'll answer Len's.
Are there any contraindications with liver disease and the solute of oil for THC and CBD?
No, there's actually work on this to show that it's safe, not just that we don't have any information, because there was some concern that people with hepatitis, with cirrhosis from hepatitis, if they took medical cannabis, that it might suppress the immune response to the hepatitis that the body naturally has and allow the hepatitis virus to flourish. And therefore make cirrhosis worse. So for a while, people were saying with hepatitis, don't take cannabis, which is actually huge because a lot of hepatitis is in people who are drug users, and a lot of them use cannabis to reduce their dependence on much worse drugs like heroin and fentanyl. So cannabis use amongst drug users is quite a commonly used therapy in a positive way, and not used as a drug of abuse in itself. They're more of for harm reduction, and the studies actually showed that wasn't the case. It didn't make the hepatitis worse.
Great, thank you. Got another one here. Says, we have a 90-year-old friend who has been on Statex low dose for years. She has cancer in her foot and has had surgery for it. She has several issues on the list she could benefit from. She's very sharp, but has been afraid of cannabis when we suggested it. Could she be a candidate for a research program? And this is from Thunder Bay. Yes,
unfortunately, we don't have a site in Thunder Bay, but if she can be affiliated with one of the study centers, so Lake Ridge Health, Kingston, Ottawa, Winnipeg. Actually, no, it's not Winnipeg, that's Manitoba, isn't it? Thunder Bay is in Ontario. If she would be able to get affiliated with one of those centers, then yes. Statex, I'm presuming, is the short-acting morphine, not Sativex. Statex and Sativex sound a little bit similar. So hopefully that's not Sativex. If they were on Sativex, which is a medical cannabis product already, they'd have to be off it for 30 days before eligibility for the study. But Statex, which is short-acting morphine, it's just one of the trade names for it, that would be allowable. The patient just otherwise has to be stable and cognitively capable of completing the daily symptom diary, symptom reporting, and also to follow the instructions. And it is a little complicated because you have the 4 bottles, and every 4 days you have to switch to another product, and you have to take them in the right order according to the randomization sequence that you've been assigned. So it does require somebody to be, fairly compos mentis to be able to do it.
Thank you. And then Boyd and Lori, you guys have a question? You can unmute yourselves.
Sure. Good morning, actually. How are you? I just wanted to ask, as a healthcare provider, I've encountered patients under my care through palliative home care. And their main concern when they were offered medical use marijuana for pain management, that of addiction. And of course, I've also have my mental health and addictions counseling, and I tried to counsel them through that. Do you have any studies or any information that could be shared with these people that are concerned about becoming addicted to cannabis for pain relief or symptom relief?
Yes, that's a good question. Remember that about 6% of the population have active substance abuse, and that's excluding, alcohol. So, you could argue that half of us have a substance abuse issue with alcohol. What's the definition of an alcoholic? Somebody who drinks more than their doctor. So people who have pre-existing substance abuse disorders or a predilection for substance abuse, if given access to high-dose THC by a route with rapid onset of effect, i.e. inhalation, yes, there is a possibility that they may become dependent on it. And you wouldn't want to suggest it for those people. So that's why, number one, you don't ever suggest inhalation, because that leads to the rapid rise of the blood level. Number two, you would never recommend that somebody goes with a high dose THC product first. They will always start low, go slow, titrate against the symptoms. If somebody appears to be developing a substance use issue with cannabis taken for medical purposes, like you find that they're starting to crave it, or they're having side effects from it, which are clearly not helpful, but they are continuing to use it despite the negative consequences, then that's newly diagnosed substance use disorder and needs to be addressed. But withdrawal from cannabis appears to be relatively mild. If people are very, very heavy recreational users, it could be uncomfortable. It may take them a few weeks really to get over it. But for most people who've just tried it for a few weeks and pushed the dose until they got side effects and then said it's not helping me, they can just stop it. They don't have to taper it. I really don't see that in people who are using it for symptom control.
Okay, because this person's main concern was that because we hadn't initiated him first on symptom and pain control, and his main concern was becoming addicted to the medical grade THC. So it was just, if I was just wondering if there is information out there that could help base the fact that it doesn't necessarily need to become addicted to it. Otherwise, we can watch out for it.
I don't know where you might find that information, to be honest. Like if you just went on the internet and searched it, you'd probably find a whole lot of people saying, don't touch it, it's going to make you turn into a zombie, all this kind of stupid stuff that's out there. But I think just reassure them that those of us that do facilitate our patients' access to it in a safe and supervised way have not seen that. Like we just don't see it.
Yeah, and that was the point I was trying to get at, is just to reassure them that no, you are taking it for the purpose of pain management and symptom relief, and addiction is the least of your worries with advanced cancer. Yeah. So
yeah, exactly.
Yeah. Thank you very much.
Okay.
Thanks, Lori. And then Daryl, you have a question?
Yep. Hi, sorry. Just had to get myself turned on here. Hey. As far as extraction oils, as you say, it is very expensive, and there's really no way I can afford something like that. So I tried doing Rick Simpson oil. I have a high indica breed that I'm growing right now under the medical license. And my problem is with the drugstores, they will not sell ethanol. I don't like using propanol because it is contaminating. And many of the growers out there that supply oil to the recreational stores use benzene, which as well, other than being highly dangerous, adds more contaminants. So I'm just wondering, is there an approach to the provincial or federal governments to get the people who have medical prescriptions to be able to get ethanol if they can't afford to buy the oil, and so they can make their own?
I have no idea. I really can't answer that question. That's out of my area of expertise. I mean, to me, it sounds like it's a hell of a lot of work, and you're probably going to have to spend a lot of money and a lot of time figuring it out. And to me, it would seem to make sense to just get a decent product from a licensed producer and just buy it. But if you have the time and the expertise, and you're willing to explore it, I think that's great. Just make sure that you communicate with Health Canada about what you're doing, and communicate with other people who are doing it, because if you've got this expert knowledge, then it would be nice to share it so that people don't have to go through the same process as you have been with learning. I mean, things like knowing about these different extracts causing contaminants. I mean, I'm not a producer. I don't have anything to do with the actual production. I just facilitates access to the end product.
Okay, thank you. Oh, could I have one more? The immune therapies versus cancer. So not hormonal treatments, that sort of thing. There's no opposition with those?
No,
Okay.
it's the ones that use your body's immune system to attack the cancer cells. They're the
Yeah.
ones. Yeah, and remember with some of it, there's traditional chemotherapy, radiotherapy, chemotherapy, hormone therapy, but then you've got targeted therapies and immune therapies. And some of the targeted therapies and the immune therapies sound very similar, the IBS and ABS, they're antibodies. So in order to know whether you're on an actual immune therapy, you might actually have to ask your oncologist what the mechanism of action of your specific treatment is.
Yeah. Okay, thank you.
Thanks, Carol. Guy? Guy, you have to unmute, sorry. Just on the bottom left of your screen, should be.
Where it says invite.
Yeah, there you go, you're good.
All right. No, I just have 2 questions, please. Is it possible to spell your email again, please?
Oh, sure. I'll put it in the, can you see the chat function? I'll put it in the chat, then everyone can see it.
Thank you.
Check. Okay.
I mean, and I have colleagues all around the country who are expert in more expert than me in this. I just happen to be the one that they've picked to do the talk. But there are plenty of good people out there, and you may find somebody who's very knowledgeable in your local area who would be able to answer questions.
Okay. My second question was just like, I remember when you talked about having the product injected like directly into the prostate cell. No study has been done on that yet. Do you know if there's something planned to go that way?
There's nothing on the clinicaltrials.gov database, which is the International Clinical Trials Registry. There's nothing on there. I checked on Saturday. So this is as up to date as it gets, really.
Okay, thank you so much.
Yeah, all clinical trials have to be registered, and clinicaltrials.gov is the most common one used worldwide. It's an American database, and if it's not there, it's ain't happening.
Okay, thank you.
Thanks, Steve. Ed?
I have a question.
Is dizziness caused by BPPV counter to using cannabis for symptom control?
Yeah, it can drop your blood pressure a few points. So like maybe 5 millimeters of mercury. And if your blood pressure's normally 125 over 90, which is high normal, and then it drops it to 120 over 80, which is normal, that's of no clinical significance at all. But if you already have blood pressure of 80 systolic, which is really low, and when you stand up, it drops to 60 systolic, a drop of 5 can be clinically significant, like you'll fall over. So it depends on the individual. So the magnitude of the effect is relatively small, but the significance can be significant if it's in a certain context.
I think the dizziness is due to BPPV, benign proximal positional vertigo.
Vertigo, yeah, that. Oh, I see that kind of dizziness. So sorry, yes, you're right. Yeah, I don't think there's any evidence. I've never seen any studies on use in vertigo, but I have seen some anecdotal reports that for tinnitus, particularly, that it's helpful. So if you have tinnitus, it probably would be worth a try because there's really nothing that you can use for tinnitus. It's a horrible condition. There's not much out there to treat it. So if you've got Meniere's disease, which is is also very common, as
Yeah.
it's associated with vertigo and tinnitus. It might be worth looking at. But I'm a palliative care physician
Sure.
and general internist, and I'm not an ENT specialist. But if you spoke to an ENT specialist, they may be aware of lots of anecdotal reports that are coming to them that are not published.
And to find out if a clinical trial is available, like through Ottawa or the other places you spoke of, how would we get that information?
It's
Through the
clinical-
database?
Yeah, I'll just it's called clinicaltrials.gov. If you just do a search for clinical trials, actually clinical trials is all one word, .gov, it'll come up. And then you can, there's a search function, and you put in your primary search and then your secondary search terms. So you could put, like I put in cannabis and cannabinoids, and then prostate cancer as a secondary search, and like nothing came up. And then, so I tried cannabis and cancer, and that came up, but it comes up with a whole load of different things that that are not really relevant, and some of them are quite technical, and some of them are not related at all. So you have to kind of filter them a little bit as you go through.
Thank you.
Okay. There are other clinical trials databases, but particularly non-English speaking countries may use. So if you Google clinical trials databases, you may find other ones that are smaller, not used as much as clinicaltrials.gov, but there are some out there, particularly the non-Anglophone ones. And there may be animal studies that don't get into clinicaltrials.gov, because the clinicaltrials.gov is for humans. If people are doing studies in animals, they wouldn't register them on clinicaltrials.gov. There may be some other registry that they use. So I can't speak for that, but there's definitely nothing going on in humans that I'm aware of anywhere in the world right now.
Thank you.
There's some genetic work they're planning in Australia, where they're going to do a study looking at symptoms, but they're also going to test people's genotypes to see whether there's a way of predicting who's going to respond better than others, or who is going to have an adverse reaction if they take it for symptoms. Which might be helpful in the future, but I'm on the peer review group for that, and we've only just done the peer review. I don't know if they're going to get funded or not for it, and it's very much in the preliminary stages, with 3 or 4 years from getting any results from that study. That's the only one I know that's looking at genes.
Daryl, did you have another question?
Yeah, whoops. There we are. Yeah, now what did I do with it? Oh, yeah, that was, I think you actually covered it just in the last couple of questions you answered there, Doctor. No, that's it. Oh, I do have a little anecdotal thing here. When I was a child in Edmonton, one of my friends came down with childhood epilepsy, and he had to leave school. They put him on drugs, and he even got worse. And his mother actually sought out illegal marijuana and would put it in a mix with heavily fatty fruits, that sort of thing, and feed it to him. And he actually recovered well enough to go back to school, no grand mals, nothing. And that was my first sort of revelation with something that was so heavily hit by the legal system.
Yeah, and that's the Charlotte's Web story as well. I mean, there's lots of kids like Charlotte, and I'm sure. I mean, there's 4 or 5 in the UK where they've now pushed through a law to allow it. So I think that there are these anecdotal reports. If you add them all together, it becomes sort of hypothesis generating, and then somebody will actually do a study. So it's definitely worth reporting them. The problem is a lot of them are not reported in the proper medical literature. They're on, various chat rooms and various internet sites, which are not totally reliable. So you don't know whether they're legitimate or not. But a properly done case report, where the medical history is reviewed and tests are reported, that these can be quite impactful, and they can be hypothesis generating, and then the studies can be confirmatory or not.